move to the last presentation, structured simulation improves learning of the fundamental use of surgical energy, FEUS, curriculum, a multi-center randomized control trial presented by Dr. Amin Madani.
Thank you very much for the honor and the privilege to be able to present our research. These are our disclosures. I have no relevance to the outcomes of the study. So we use energy devices every single day in the operating room, and they're obviously extremely helpful, whether it's for dissecting tissues, whether it's for hemostasis or ablation. However, there's a flip side to it. Number one, they can lead to very severe and significant complications to patients. And secondly, there tends to be a very poor understanding amongst the operators, surgeons, and surgical trainees regarding the safety features of these devices. So in order to address this patient safety issue and this knowledge gap regarding the safe use of energy devices, SAGES has developed the Fundamental Use of Surgical Energy Curriculum, or FEUS. Many of you have had the opportunity to do this curriculum by now. This is a series of online modules that are available for free, and there's also a validated certification exam to go with the curriculum as well. However, as some of you may also have noticed, FEUS is an entirely didactic program. There is no hands-on training or assessment component. So what we did was, at our curriculum, we developed an electrosurgery course for surgical residents that has both a didactic and a hands-on benchtop simulation component to go with it. The idea is that there's certain concepts and principles in the curriculum that are often difficult to understand, and so we thought that by using a benchtop model, perhaps we can improve the effectiveness of the learning. We conducted a previous pilot, a single institutional study, where we were able to show that this benchtop simulation was effective in improving knowledge of electrosurgery safety up to 3 months later. However, it still remains unclear whether or not these outcomes are reproducible and therefore applicable to a variety of different residency training programs. So before we start advocating this curriculum to be adopted widespread throughout all residency training programs, we first have to establish the generalizability, because residency training programs can vary significantly in terms of instructor availability, resident volume, and availability of resources. So the purpose of the study was to estimate among surgical trainees to what extent does adding a structured benchtop simulation improve how much knowledge you acquire from the curriculum across multiple surgical training programs. To answer this research question, we conducted a randomized controlled trial that was multi-center. We recruited junior surgical residents in first and second year, and we traveled to 11 residency programs throughout Canada, the United States, and the UK to give this course. Surgical residents that were recruited, regardless of subspecialty, underwent a pre-curriculum baseline assessment to measure their level of knowledge, and I will expand on this assessment tool momentarily. For the first hour of the course, this was the didactic component, we gave them a lecture that was based on the FEUS content. Subsequently, they were randomized into 2 groups for the second hour of the course, which is the hands-on component. In the control group, it was an unstructured simulation environment. So they had access to electrosurgical devices, inanimate objects. There was stake, and they got access to that, and they got the opportunity to experiment and play around with the equipment. And this is really meant to replicate what we currently get in our residency training. In the intervention group, it was a very similar setup. Same equipment, same devices, the stake and all that was the same. However, instead of an unstructured environment, it was much more structured. There were specific goals and objectives that had to be achieved throughout the training session. There were specific modules and tasks that we designed to complement the lecture and to help better reinforce some of those key principles of safety. Subsequent to that 2-hour course, we did a post-curriculum assessment, both immediately and 3 months later. This is what the curriculum looks like. We teach everything from the basic fundamentals and principles of electrosurgery all the way to the adverse events that could occur, both in open and in laparoscopy. And really, that's where the key learning happens, by recreating these scenarios and showing how adverse events can occur. And there's a lot of debriefing that goes into this to teach them the mechanism of injuries and what kind of steps to take to mitigate such risks on patients. The assessment we used was a multiple choice examination to assess knowledge. We had a separate pre and post examination. There were 35 items. And these are not just random questions that we just threw on a piece of paper and gave to the residents. The content comes from the FEUS blueprints. So the FEUS certification exam that many of you have completed has undergone a 3-year-long validation process. And part of that process requires the creation of a blueprint. So you give more questions and more items on the exam on those things that are deemed to be more important and more relevant to the target audience practice. So we use that same blueprint to create our assessment tool in order to give it more rigor and validity. We also establish good internal consistency and inter-class correlation between the pre and post-exam. This is what the exam looks like. So there's different subsections to it. I highlight to you that during the hands-on component, these were the 3 subsections that were really emphasized. There was a strong representation from these objectives from those sections. So when we look at the results, we expect to see an improvement in knowledge. It's in those subsections that we expect to see the improvement, not in the other ones that were not represented in the hands-on curriculum. So let's look at our results. We had 354 residents, 65 were excluded because they did not attend their teaching, so 289 were randomized into one of 2 groups. After 3 months, our dropout rate was approximately 30%. It was similar in both groups. In terms of the baseline characteristics, both groups were similar. One group was not at an advantage compared to the other. Let's look at our primary outcome now. This is a total exam score. This is total exam score. So in the white, you can see the control group, and in the dark gray is the goal-directed simulation group. At baseline, you see that their scores are, not only are they similar, but also very suboptimal as well. After the curriculum, you not only see that both groups did significantly better after the curriculum compared to their own baseline, but also that there's a significant improvement in scores in the intervention group, the one that had the goal-directed simulation, although the difference between the two is pretty marginal with just a few percentiles. 3 months later, we again not only see a significant difference in the goal-directed intervention group, but also that the difference between the 2 groups now starts to become much more pronounced. Furthermore, you notice that there's less variability in the scores of the goal-directed intervention group, which is also a sign of additional expertise in that group. Also, there was drop in knowledge over time in both the control and in the goal-directed simulation group. And also, we were able to show a significant improvement in knowledge in the intervention group compared to the control group in all 3 of those subsections that were emphasized in the hands-on component. But we were not able to see that difference in the other 3 subsections, which further adds more evidence to the fact that it was the intervention that was responsible for that added benefit. And lastly, we did a multivariate linear regression model after adjusting for age, gender, institution, and residency program, and we were able to see that the 2 predictors of 3-month scores were whether or not you participated in a goal-directed simulation, the intervention, and secondly, the baseline pre-curriculum total score. So if you started off with a better score, then you're more likely to have a better long-term retention as well 3 months later. So in summary, a 2-hour FEUS-based electrosurgery curriculum improves knowledge up to 3 months after the curriculum. And this was a result that we were able to notice across various training programs and learning environments, as we were able to establish that generalizability. The addition of a structured goal-directed benchtop simulation component, we were able to see further improves knowledge that you acquire from the curriculum and further improves retention. So in conclusion, the addition of a structured interactive benchtop simulation to a FEUS-based electrosurgery curriculum further improves learning and retention. And I just want to thank the SAGES Foundation for providing a SAGES research grant last year. We're really, really appreciative of that and made this study possible. Thank you.
Thank you very much. Please go on.
Amin, this was beautifully designed, executed, and presented. You know, all of the other fundamentals have hands-on components, and when we began the FEUS program, you know, what to do really didn't seem very clear, so we started it with a curriculum. What are the advantages and disadvantages of your approach with steak and eggs and all the other fixing hash browns and versus perhaps a virtual approach? I mean, which way, if we were to add some more training, which you clearly demonstrate may be needed, what's the pros and cons of the different ways of doing it?
Thank you. I think that's a very important point that you raise, and certainly with the VEST project, you're developing a virtual reality environment to also further emphasize some of these important teaching points. I'm not so sure that the exact technology is as important as the actual content of the curriculum that's delivered. A simulation can be very effective regardless of how it's developed, whether it's in a VR or a benchtop model. So, for instance, the FLS, it's a very simple benchtop model, but it's highly, highly effective. And I think it's when you take a simulation and you package it in a way that's centered around educational objectives, that's when it becomes highly effective. So I think if the VR comes out and it's similarly effective, centered around educational objectives, the content is delivered in an appropriate way, there's appropriate debriefing that happens, and you really emphasize some of those teaching points in an active learning approach, then I think it would be equally or maybe better than this model.
Hi, Matt Ritter from Walter Reed, Bethesda. Congratulate you on a nice study, nicely presented, nicely done. In your presentation, you refer kind of to a proficiency-based model for your experimental group, kind of a mastery learning type model. How, with such a large group, did you ensure that each training goal or training objective was achieved during that structured session? So, like, what type of assessment, formative type assessment did you do to say you're okay to progress to the next module?
Thank you, Dr. Rader. That's a very important question. I agree with you. What we did when we traveled to all those different sites, the intervention group was actually delivered by myself and a colleague of mine, Dr. Watanabe, who's in the crowd. And so that's how we assured that we made sure that every resident in the training group achieved their proficiency level. There wasn't a standardized way, there wasn't a checklist assessment of any kind. It was mostly subjective, and I would pimp a lot the residents. I would ask them questions, I would ask them if they understood, and if they didn't, I would keep explaining until they did. So that kind of deliberate practice was delivered in the teaching. And I think that's important because, and that's probably one of the limitations of this study, is that how do we ensure that this kind of teaching can be delivered across multiple training programs? And we did this partly due to simplicity, because it was difficult to train a local PI to give the course at every site. However, I hope that it is as effective. We could show that in future studies.
Okay, please.
Dimitris Stefanidis, Charlotte, North Carolina. Thank you for an excellent study and with very clear findings and impressive results, organizing all the sites. Congratulations to do all this work. My questions are about, you assessed the effect of hands-on skills training on knowledge. Did you consider including a hands-on assessment component as well? And if so, how would that look like? And do you have any thoughts about how to assess resident performance in regards to FEUS in the operative room?
Thank you very much. Those are very important points, and definitely we considered those things. So the first one is so maybe I'll answer the second question. So the one where you asked about looking at the transferability of what you learned from the curriculum into the clinical environment. I think that's very true. Right now we have no evidence whether or not there is transferability, especially in light of the fact that there's a big drop in knowledge over time that happens. We considered doing that study. However, it's very unfeasible given the fact that they're relatively rare injuries that happen, and secondly to the fact that electrosurgery related injuries, the reporting is also unclear as well. So, and you require a very, very large sample size to conduct such a study with very long follow-up period. So I think that because of that, we didn't pursue this. In terms of doing a hands-on assessment component, we definitely considered that from the beginning of my thesis. In fact, we went to the Learning Center 3 years ago, and we actually had a series of tasks set up, and the idea was to see whether or not we can create these scenarios with error traps and see whether or not residents can pick up on these errors, and whether or not we can create a checklist or a global rating scale and so on. However, again, with the inanimate tissues, this was very difficult, and the feasibility was just not there. However, this could be something that I think would be really good for a VR environment. And if many of you had the chance to go to the Learning Center, put on that Oculus program, you can put somebody in an immersive environment and really recreate that scenario with the good fidelity. I think that would be a very nice, this would be something very useful to do. But in this benchtop model, we had a lot of difficulty doing that.
I mean, very nice work, and I congratulate you on implementing this hands-on training. The differences you saw in assessment were not that great, even at the 6-month time point. What about adding online learning, self-directed learning to complement this? That seems to me that would be really the way to enhance difference in performance.
I agree. I think having the availability of online tools would be highly useful, and especially due to the fact that there's a drop in knowledge after a few months. And in fact, we actually looked at long-term outcomes as well from the pilot study, looking at 1-year follow-up data as well. And you can see that there's even much greater drop in knowledge over time. So the availability of these online tools would be really great to keep reinforcing these principles of safety, despite the fact that we use electrosurgical devices every day in the operating room. In terms of whether or not to have an online module versus just the hands-on component, I'm not entirely sure whether or not there would be a difference, and we'd have to do further studies to assess that.
Okay, there is a question from the audience. Did you consider involving plastic surgeons in the study group? Why only limit the study to junior house staff?
We definitely considered it. From a feasibility standpoint, I'm not sure it would have happened. So junior residents are very easy to get a hold of and to perform a multi-center study on. And these just started their training. They're very keen on learning. They're more likely to recruit as well. And most of the time, or at least in Canada, they have protected teaching time as well, which we can really capitalize on to perform the study. So it was really purely for a feasibility standpoint. But if we can do this on practicing surgeons and to organize postgraduate courses maybe at the simulation center or something, that would be really, really nice. However, it's hard to bring practicing surgeons into that environment to do this study.
Thank you very much.
Thank you.